We're going to start today's lecture off with pulmonary embolus and talking about some of the things that may or may not be familiar to you and why pulmonary emboli develop, how we would determine that they have a pulmonary embolus, and then essentially what some of the different treatments are for that. So looking at the objectives, we're going to talk about some of the physiological effects of a pulmonary embolus, meaning how does it affect the normal physiology. And if you can kind of remember back, there's physiology and then pathophysiology. And anytime we hear the word patho, we should be thinking of some sort of an abnormality. So a physiological effect is what is normal. So how do pulmonary emboli affect the normal function of the body? We should also understand where the pulmonary embolus originate and why they occur. And there's different mechanisms for that, as we know. You know, being an EMT or paramedic school, you probably recall your instructor talking about individuals that are a higher risk for developing a pulmonary embolus. So a truck driver, maybe an airplane pilot, or a passenger on a long distance airplane flight, those that have had recent surgery, particularly in the lower extremities. So those are going to be increased risk for patients to have a pulmonary embolus, and it's because of the immobility. So we're going to look at that, but then separately, we're going to talk about those that are taking oral contraceptive medications, and then also discuss a little bit about an amniotic fluid embolus in the pregnant patient. So it's all kind of the same end result, but the reason that they occur and how they occur are completely different mechanisms. So we'll take a look at that. We're going to talk about the stereotypical increased risk factors associated with pulmonary emboli. And some of you may kind of already know what those are, hence the quotations of stereotypical, the female that is a smoker and also on oral contraceptive therapy. Those patients are going to be obviously at an increased risk, and we'll look at some of those numbers. And then we're going to talk about the correlation between pulmonary embolus and the transgender community. And again, Brandon and I, we do a lot of discussing about the topics and what we're going to talk about. And we try to make sure that we're always maintaining professionalism, regardless of what side of the fence you are on with regards to some of these things that are kind of hot button topics. But the reality is the transgender community, they're at a much higher risk for developing a pulmonary emboli, and we're going to talk about why that is. And it's because of some of the medications that they are taking. So we'll take a look at that. But we wanted to make you all aware that the transgendered population is going to be at an increased risk for developing a pulmonary emboli because of the medications that they're going to be required to take. So epidemiology, you know, I always like to start lectures off talking about epidemiology because it kind of puts you in the mindset of, okay, well, why do we even talk about this? Why do we care? Why does it matter? I'm never going to see this. And the reality is we are. If you do this job long enough, which, you know, I know most of you that are logged on right now, and the reality is you are going to see it, and you probably have already seen it. And that's because the numbers are pretty, you know, not as high as some of the other things that we deal with, but they're high in relative speak. So 237,000 non-fatal pulmonary emboli occur every year in the United States. And the problem is those are the ones that are living. It's basically outweighed by those that cause fatal pulmonary emboli, and that's at a rate of about 294,000. So there are more people that develop a pulmonary embolus in the United States that die from it every year than those that develop a PE and have survivability. So that is a problem. We need to be aware of what the treatment options are and what we can do to try to better assist our patients. And then the patients need to be more aware that, you know, maybe I'm suffering from a pulmonary embolus. So I think some of the educational materials that maybe could be put out into the public, kind of like they do for stroke or heart disease, may help to kind of flatten this out a little bit. But for the time being, those that develop a PE are at a higher risk for dying than surviving. So the pathophysiology here, basically, in a lot of you probably remember or recall this from your basic training, but if we have any type of an obstruction in the pulmonary artery or one of the branches, we are going to end up developing a pulmonary embolus potentially. So I always like to explain this when I'm doing any type of review for our paramedic students, or if we're doing any type of tutoring for those that are trying to pass the National Registry exam. Most of the time, and you're going to see this here as we talk about DVTs or deep vein thrombosis, a lot of times what is actually occurring is you end up having stases in coagulation in the vessels in the lower extremities, and then that clot breaks off. And when the clot breaks off, it really doesn't have a problem getting up through the femoral. It doesn't have a problem getting up through the inferior vena cava. And we're going to talk more about the inferior vena cava and why they put filters in there. But it has the ability to get up through those vessels because they're a relatively decent size in diameter. So if you can kind of just vision, you have a clot in your leg. It's coming up through the inferior vena cava. The IVC basically dumps into the right atrium. The right atrium is a large chamber, no issue there. It goes through the tricuspid valve. It gets into the right ventricle, and I'm just doing normal flow of the blood in the heart. Once it's in the right ventricle, again, big chamber, not a problem, makes its way through the pulmonic valve and then into the pulmonary artery. And the reason that it lodges in the pulmonary artery is because that is the smallest structure that it comes in contact with first. So if that clot develops in that or lodges in that pulmonary artery, clearly we're not going to have the ability to get any blood flow past that area. So things are going to start to back up. If we can't get blood flow to the lungs, we know that clearly we're going to end up having a reduction in our ability to breathe. We're going to become hypoxic. We're going to have hypoventilation. So there's all kinds of signs and symptoms that are going to go along with that. But one of the important things, and for those of you that are in class or getting ready to test at any level, that I think you guys really need to understand the concept of is this. This will be a quick onset finding. So these patients are not going to have chronic conditions that have been going on for weeks and months and years with this difficulty breathing. Their complaint is going to be a sudden onset of difficulty breathing, and oftentimes it's going to be referred to as a sharp chest pain. And that is because if you think about it, that clot is not causing problems as it's in the inferior vena cava. It's not causing problems when it's in the right atria, the right ventricle. It only becomes a problem once it gets to a portion of a vessel that is too narrow for it to pass through. And that is when the patient suddenly feels that they have difficulty breathing, and they do. And that's simply because the blood flow can't make its way to the lung. So the obstruction of the pulmonary artery or one of its branches by a thrombus that originates somewhere in the venous system or in the right side of the heart. And it's going to be in the right side of the heart because we know that the right side of the heart is what is receiving blood from systemic circulation, trying to get back to the lungs to reoxygenate so that it can circulate around one more time. So most commonly, the pulmonary embolus begins as a DVT or a deep vein thrombosis. And some of you may have had family members that have suffered for this, and they should be aware of what DVTs are. They need to be compliant with their medications, so on and so forth, so that they're not at a higher risk for developing a pulmonary embolus. We can live with the DVT. The DVT is not really that big of a deal as long as we can keep it under control and keep that clot or thrombus from breaking off and traveling into that pulmonary artery. That is the challenging part, though. We really don't know how effective we're going to be to do that. And really, you're not going to know that it's a problem until it is actually a problem. So if you have a history of DVT or your family has a history of DVTs, make sure that they're well managed medically and that they're taking their medications like they're supposed to try to reduce the complications or the possibility that they end up developing a pulmonary emboli. So that thrombus formation in the deep veins typically occurs in the calf or thighs, and a lot of times this is related to valves. So if us medics will oftentimes say that, I'm trying to start this IV and I think I'm up against a valve. There are valves that are inside the venous network. There are definitely valves that are in the lower extremities, and their job is to try to get blood flow back to the heart. So it's really a one-way valve. Well, those valves, sometimes they become sticky, if you will. They don't really work the way that they're supposed to, especially if the patient has any type of varicosity, varicose veins. They're at a higher risk for developing some of these DVTs, just simply because the blood flow can't get through that valve the way that it once did. And then, the result is that they have coagulability of that area, and then eventually that clot breaks off and then travels to the lung, hence your pulmonary embolus. All right, so there are different types of clots. And this is just from basic information in EMT or paramedic school. So there's fatty type clots, and these are made up of cholesterol or fatty substances, and they can just clog the arteries themselves. So this can be from fatty foods. They can develop from long bone fractures if you get some of the soft tissue involvement into those bone type fractures. They can end up getting a fat embolus. But a lot of times this is going to be related to cholesterol and just poor diet and exercise, those types of things. You can get an air embolus, and these stem from IV catheters. Maybe it's an infusion, those types of things. And it can also be found in your scuba diving population, also known as the bends. And we'll talk a little bit about that here in just a second. With regards to your catheters and infusions, one of the things, and I learned this very young in paramedic school, doing time over at the University of Cincinnati, I had to change out a bag of saline and had never really been shown how to do that. So I roll the clamp down, I disconnect the tubing, I spike the new bag. Well, I didn't really anticipate the amount of air that I was going to end up putting in the line, which was pretty significant. So if you're not familiar with how to do that, there's actually a couple different ways, but have somebody in your agency that can show you how to switch out a bag without getting air into that line. And if all else fails, basically what you do is you can respike the bag and then hook a syringe up to one of your ports, open your roller clamp, and as the air starts to make its way down to the port that you have your syringe attached to, you can simply just withdraw the air off so that it doesn't make its way into the patient. Is a little bubble in a tubing, a macro or a micro tubing, going to cause a lot of damage for your patient? And the answer is no. It's going to cause a lot of problems for you if your patient is on a pump, because the pump is going to continue to beep and you're never going to get anything else done. But if it's flowing via gravity, a bubble or two, it's not going to cause any problems for you. In order for this to actually cause problems for your patient and to the point that you need to worry about an air embolus, the whole tubing would need to be filled. So it's a pretty significant amount of air that would have to be in there. So make sure that you're not causing problems from your IV catheter, you're changing out your tubing, so on and so forth. The other thing is the scuba diving population. So they can end up getting something called the bends, and this is actually also referred to as nitrogen narcosis. And essentially what happens in your scuba divers is they should do surface interval stops. And if you're a scuba diver, you know what I'm talking about. If you're not a scuba diver, then basically what you would do is, if you have been diving, we'll say at 100 feet, and you're trying to make your way back up to the surface, you cannot just come directly back up to the surface. So there's a few rules that you need to follow. One of which is you should never ascend quicker than your slowest bubble. So as you're exhaling and you're seeing your bubbles go up, you should never be quicker than that last bubble, because that's telling you that you're simply coming up too quick. And then in addition to that, you should have surface intervals. So you should stop a couple of different times and let your body kind of regulate. This isn't a diving lecture, but I'm happy to talk offline with you about diving or the bends if you guys have any interest in that. But essentially what you're going to do is stop at certain intervals and make sure that your body has the ability to kind of regulate and get rid of the nitrogen that you're holding on to, because you're under a pressure. And that's what ends up happening, is because the atmospheric pressure is higher. At 33 feet is your first atmosphere as you go down. So that pressure is going to not allow your ability to off gas the way that it should. So that nitrogen basically ends up getting caught in some of your bones and muscles, and it becomes very painful, and the patient will become very sick. So the treatment for this, if they end up having the bends, is you have to put them into hyperbaric therapy. So they would end up putting them into a chamber, taking them back down to atmosphere, and then essentially doing that surface interval that the person probably just failed to do on their normal ascent. An amniotic fluid embolus is kind of an interesting thing. So you can end up getting small lacerations in the uterus. during the pregnancy and shortly thereafter birth. So some of the fluid can actually make its way into the bloodstream through those lacerations that have occurred. And that is what develops an amniotic fluid embolus seen in your pregnant population. And then septic patients, and this originates from either bacterial invasion of the thrombus, or it can be through other mechanisms, but bacterial invasion is probably the most common with regards to the patients that are getting clots or pulmonary emboli from a septic type of issue. So there's something called Virchow's Triad, and this is a triad that kind of tells people whether or not they are predisposed to having a deep vein thrombosis. And the three sides of this triangle here are intravascular vessel wall damage, a hypercoagulable state, and then stases of flow. And when we talk about stases of flow, all I am referring to there is not having proper flow. Okay, it's stagnant. It's not moving the way that it's supposed to. So this was discovered by Dr. Rudolf Virchow, and Dr. Virchow was a German physician, and he was around from 1821 over to 1902. In Virchow's triad, he really first kind of described what this triad was in 1856, but interestingly enough, he was not the one that actually identified the Virchow triad, and it wasn't done until many years after his death. So he was the one that identified what it was, but never actually put a name or anything to it. And then through additional research many years later, they started to figure out, like, wow, this guy was really smart, and the things that he was saying back in 1856 are absolutely true. We should name this after him. So it's kind of an interesting thing, because a lot of times it does not happen that way. Somebody else will take credit for the work that was done, but they did not in this situation. They gave it to Dr. Virchow. So with the intravascular vessel damage, so if we're looking at the left side of the triangle, the damage is going to alter the dynamics of blood flow. And the easiest way that I can kind of relate this to firefighters in the room is talking about any type of turbulence or friction. So we understand that with regards to hose lines and how we're going to have friction loss, and that's because of turbulent blood flow. So if we have any type of damage to the intravascular vessel, it's clearly going to end up creating some turbulence, and we don't want that. With turbulence becomes friction, and that is where some of the problems start to end up developing. So the inside of the vessel, the tunica intima, ironically enough or interestingly enough, is, stand by 1 second here. I'm having some difficulty here. Just give me 1 second real quick, you guys. All right, so that intravascular vessel damage is going to create that turbulence, and that's going to end up, for the firefighters, it's going to end up causing friction loss. It's also going to cause problems inside of your vessels, and that is what's going to happen here with this intravascular vessel damage. So this can result from smoking, chronic hypertension, atherosclerosis, and all of those other things that end up leading us down the path or getting there from a bad path of not taking care of ourselves and some of these things that are modifiable risk factors like smoking. Chronic hypertension you really can't fix, but you can treat and you can keep it under control. And then atherosclerosis, again, some of the things that we can do in our personal lives can help to make that better. As far as the turbulent flow, this is when that blood flow becomes too rapid and it creates a disordered flow or an eddy of current, if you will. So it's not getting through as easily as it should. And this increases the friction within the vessel. Same thing as we're talking about with firefighting. And this is because of that plaque formation. It may be from vessel bifurcation if you have different vessels that are kind of shooting off of one another, which we know happens. And then stenosis or vascular disease. And this is where talking about the valves in the legs, the lower extremity, that is where that stenotic valve and some of those other vascular diseases will come from. So we know that that is problematic as well. All right, and then stases of flow, the other side of the triangle or the bottom side of the triangle, is more likely to occur in patients with atrial fib, anyone that has a valvular heart disease or prolonged immobility. And then decreased blood flow here causes an interaction with surface proteins that lead to thrombi production. So we know that these are all done from chemical mechanisms within inside the body. And essentially what ends up happening is you have these proteins that start to interact with one another with things that should not typically be there because of that decreased blood flow. Now they have the ability to kind of stick, and that's what ends up leading to some of this thrombi formation. So the AFib patient or anybody that has had any type of valvular heart disease and has had a valve replacement, most of the time these individuals are going to be on either Coumadin or warfarin, if you will, and then they're going to end up having to have an INR drawn. So an INR is basically a blood test that is going to tell the provider how thick the blood is and how much they have to worry about clotting. So just to kind of give you guys an idea, because we've been asked to do these things, and maybe you have a family member that has to do INR ratios to figure out what their blood level is. So anything less than like a 1.1 would typically fall into a normal finding. If a patient is on warfarin or Coumadin because they have AFib or because they've had a valve replaced, then they're probably going to be more in a therapeutic range if they're around a 2 or a 3. They don't necessarily want that to be much beyond that, because that obviously increases the risk for the patient to have head bleeds if they fall and strike their head. And we know that this is the population where that starts to happen. So they have an AFib finding, they start putting patients on Coumadin, and then the patient trips on an area rug at the house, they smack their head, they end up with a subdural bleed, et cetera, et cetera, et cetera. So DVT and predisposition with stasis of flow because of some of these prior conditions is a very real thing. And as always, they need to be medically followed as well so that they can keep their levels within an appropriate range. And then the hypercoagulability. So this just means that they're more likely to coagulate or clot. And this can occur in the presence of a variety of conditions, pregnancy being one of them, oral contraceptive medications, and we'll talk about the oral contraceptive medications and which ones they are, cancer, lung and pancreatic cancer specifically, some of the chemotherapy medications, and then patients that have an inherited thrombophilia. So those are the 3 sides of this triangle that make up Virchow's Triad, and it's been proven over and over and over. Although there has been, it used to be the one side just being a clot, and now they've really kind of focused, they've modified it a little bit, and they're talking more about what actually causes the clot than just the clot itself. So we've identified that coagulability is certainly a thing. Now let's try to figure out why they're coagulating the way that they are so that we can try to break that cycle, and that's where the focus is at this point. So pathophysiology for VQ mismatch. This was something that I know that when I was in paramedic school, we would talk about a VQ mismatch, and I don't know that I really ever understood exactly what it was. So the V and the Q, V is actually pretty easy to understand. V is ventilation. The Q is the one that kind of throws people off. And what Q is perfusion. So we have a ventilation perfusion mismatch. And we know that ventilation is the mechanical process of moving air. And then perfusion is actually getting the oxygenated blood where it needs to go. Okay, so that is where the problem comes in. So in your individuals that have any type of VQ mismatch, and for all intents and purposes, what a VQ mismatch is the lung is getting an appropriate amount of oxygen. It just doesn't have the blood flow to go with it. So it is not getting there through the normal mechanism, and that is where this VQ mismatch ends up coming into play. So they end up with arterial hypoxemia. So they have a low amount of oxygen in their blood, in their arterial blood, is compensated by increased minute ventilation. So how quick they are breathing in a minute. And they end up blowing off more carbon dioxide than they need to because of that increased minute ventilation, and it ends up creating this VQ mismatch. So there are 2 classifications really. Individuals that have upper airway obstruction, choking, those types of things, they're at a risk for VQ mismatch. But specifically today, the group that we are talking about are the individuals that will end up developing a PE, or a PE will end up causing this VQ mismatch. because of this increased minute ventilation, causing them to blow off more CO2 than necessary. And then it's just kind of a cyclic going downward spiral from that point. But that is why they end up with the VQ mismatch that we've been talked about since EMT and or paramedic school. So the deep leg veins, so what are they and why do we hear so much about them? And you may hear, a deep vein thrombosis, right? So the DVT that we've already kind of referred to. If you go by definition, there are 7 different deep veins in the lower extremities. And some of them are on here. You have your popliteal vein right here, where the kneecap would be, the anterior and posterior tibial vein, the perineal vein. So there are 7 different ones that make up these deep leg veins. And then we have varicose veins, and these are incompetent or leaky valves in the veins that we've already kind of talked about. And that varicosity is where some of the problems come in, creating the stases in the leg. And then that clot ends up breaking off and then traveling back up to the right side of the heart and then ultimately into the pulmonary artery. This is the same concept and mechanism that we talk about when we refer to atrial fib patients. So, if you're new to this or you're in class, one of the things that we always refer to is a patient that has atrial fib. They're at an increased risk for having a stroke. They're also at an increased risk for having a pulmonary embolus. And this is why. The heart is not pumping the way that it's supposed to. So the blood just kind of sits there and it pools and it starts to coagulate, the same thing that is happening in these deep leg veins, which ultimately end up breaking off and then going to the right side of the heart or the pulmonary artery. So same concept, different mechanisms, different areas of the heart, but atrial fib and these deep leg veins will in theory end up causing a lot of the same problems. So those valves that we referred to, it allows the blood to backflow distally into the vein, and that should not occur. Under normal conditions, that valve should open up, allowing for blood flow to go back to proximal circulation, back to the chest. But because these things are not working the way that they're supposed to, because they are stenotic at this point, that backflow goes down and it causes that stasis and pooling that we're already referring to, in addition to the patient that has immobility, because it may be that they just are on that long airplane flight, or they're a truck driver, over the road truck driver, or it may be that they have immobility because they're on bed rest due to pregnancy, or they just had a recent surgery. Those are the patient populations that we really need to be paying attention to. All right, pulmonary emboli in pregnancy. So patients during pregnancy are also at an increased risk for developing a pulmonary embolus. And in the mechanism, we've kind of already talked about a little bit. But during pregnancy, the uterus is compressed against the iliac vein. So same concept here. We're not able to get the blood flow from the venous network back to the right side of the heart. And when we have a reduction in blood flow, we're going to end up developing clots. So that compression of the iliac vein, not allowing the blood to get back where it is designed to go, is going to end up increasing the risk of the patient getting clot formation and then an eventual pulmonary embolus. After birth, on the other hand, and this is the one that we've talked about a little bit, the amniotic fluid and microclots from some of the bleeding that will occur end up getting into the lacerations in the uterus that are there because of the simple process of birth. And then eventually it's going to make its way into the bloodstream and back to the right side of the heart. And this is referred to as an amniotic fluid embolism, but the result is going to end up being the same thing. Sudden onset of difficulty breathing and chest pain. And essentially what they're going to have to do is get that fluid embolus out, or that clot out, whatever it is, whether it be air, whether it be fluid, or whether it be a thrombus. They're going to have to try to get into that pulmonary artery and remove the clot. Otherwise, the patient is not going to have a good outcome. So oral contraceptives and blood clots, this is kind of an interesting thing. There's really, it's all tied to basically drospicerone is one of the medications that are one of the constituent parts that are in these medications as far as your oral contraceptive medications. So it is not every oral contraceptive medication that women take that will lead them to be at an increased risk for having a pulmonary embolus. In fact, some of the information and some of the studies that are out there that we end up getting on the other side of one of my jobs, is that they don't really know that it 100% is linked to that. But there is an increased risk in findings over many, many, many years of individuals that are on oral contraceptive medications having an increased risk of developing a pulmonary embolus. So about 17% of females that are childbearing age take some form of oral contraceptive. And this doesn't necessarily mean that the patient is sexually active. A lot of times they will do this to regulate menstrual bleeding, cramping, and pain that comes along from month to month. So the fact that they are of childbearing age and they have the ability to have a menstrual cycle, sometimes parents will put their children on these medications pretty early on, even if the child is not sexually active, just to try to regulate some of the bleeding and the pain that goes along with that. So, you know, when we're looking at 20% of females of childbearing age, basically, that's a pretty high number. So this is something that we should be aware of. The increased estrogen and progesterone levels are what are going to lead to increased clotting mechanisms. And that's where I'm kind of talking about. It's specifically one thing that is in some of these medications that actually has been linked to that. So it is not always just an estrogen or a progesterone. It really depends on the type of medication that they are on. But other things that go along with that are increased triglyceride levels, increased red blood cell concentration, and then it lowers good cholesterol and increases bad cholesterol. So it kind of does things in the reverse from what we'd under normal conditions like for it to do. As far as the transgender community, so actually, let me back up just here 1 second. So to put this in perspective, this oral contraceptive and blood clot, for individuals that are not on any type of oral contraceptive, and this is where these numbers are coming from and why they think that they're at an increased risk. The patients that are not on any type of oral contraceptive, it's like 1 to 5, 1 patient to 5 patients per 100,000. For individuals that are on an oral contraceptive containing estrogen primarily, and the other constituent part that I've already mentioned, those are like 3 to 9 per 100,000. So we know that there is an increased risk, but it is not as high as a patient just having a developing PE from just being pregnant alone. So pregnancy alone and after pregnancy, immediately after the baby is born, the female is at a very, very, very high risk of developing a pulmonary embolus. And to kind of put that in perspective, when we're talking about 1 to 3 or 1 to 5 and 3 to 9, just pregnancy alone and after pregnancy, they're at like 40 to 60 per 100,000. So yes, oral contraceptives have been linked and thought to cause increased problems for your pregnant patient or your non-pregnant patient. But certainly the pregnancy alone and the after pregnancy place the female at a much higher risk than just taking oral contraceptives in the attempt to either regulate the menstrual cycle or prevent pregnancy. So it's kind of interesting there that we always hear about, if they're on contraceptive therapy, they're at an increased risk. And maybe as a parent, you've hesitated putting a child on there, you've had issues talking with a spouse about whether or not they should be on some of these medications because it increases their risk. They're certainly, and this has been proven over and over, they're at a much higher risk of just developing a pulmonary embolus during the pregnancy than they are from being on the medication. All right, the transgender community, and this is kind of an interesting thing and why we felt that it was appropriate to talk about it, regardless of your position, regardless of our position. There is a transgender community, and in Kentucky alone, and I know not everybody is in Kentucky that's on, but in Kentucky alone, there's 17,700 transgendered adults. And yes, it makes up for less than 1% of the state population, but 17,700 is not a small number. So Kentucky itself ranks 26th in the United States with regards to the transgender population. Clearly, there are other areas that are more, it's more prominent. And if you're functioning or working in one of those areas, then you need to be even more aware of the situation. So in 2019, the American Heart Association recognized that male sex at birth transitioning to a female had an elevated risk of cardiovascular disease. And what they did is they analyzed 2,500 men that were transitioning to women, and they found that they were 2 times as likely to have a stroke, 2 times as likely to have an MI, and 5 times more likely to have a DVT or deep vein thrombosis that we're referring to. So here's why. The transgender patient, if they're talking estrogen and they're doing any of the hormone replacement therapies, a transgendered patient is going to take 100 milligrams of medication. And when we're talking about a patient on birth control that we just discussed, it's anywhere from 10 to 35 micrograms. So you can see and appreciate, hopefully, that the 100 milligrams is a much larger dose that your patient that is transitioning is going to be required to take, as separate from the birth control patient that we have talked and everybody is aware of. Prior to me talking about pulmonary embolus today, I would venture to say 90% of the people that are sitting in listening to this lecture at some point in time had heard about oral contraceptive therapy causing an increased risk for a pulmonary embolus. We've all been taught that in EMT class. We've all been taught that in paramedic school, and they're at a much, much, much lower dose than the patient that is transitioning from male to female. It's interesting too, females transitioning to men don't have the same issue because of the hormone replacement therapy. They are not taking that hormone replacement therapy like the male transitioning to female. So it is definitely a one-way thing with regards to the patient having an increased risk for pulmonary emboli. So what about clinical presentation? I've kind of mentioned some of these before, but chest pain, and specifically with chest pain and difficulty breathing, what I think is important is for you guys to realize this is sudden onset. So sudden onset of chest pain and difficulty breathing, they're going to have tachycardia, and that makes sense. A lot of these are common sense if you just think about it. Why would they become tachycardic? Well, because they can't breathe. So it is a release of catecholamines, epinephrine, and norepinephrine, causing them to say, hey, I can't breathe. I got to go into fight or flight mode, and that is why I'm going to become tachycardic. I'm also going to become tachypnic, so I'm going to increase my respiratory rate. I'm going to have hypocapnia and hypoxia. I'm not going to have the ability to have good CO2 and gas exchange and oxygen. So I'm going to become hypocapnic and also hypoxic. I think it's kind of interesting here in the picture that this patient kind of has that bluish coloration or discoloration over the eyes. So this is something that, just speaking from an experience thing, if you make a cardiac arrest and there's no evidence of any type of entrapment or asphyxiation, and you find that they are bluish or purplish, typically from the nipple line up, and that makes sense because that is where the problem is, the lower extremities. Basically, they don't have the issue. It's the upper extremities because of where the clot formation is at, which is in the pulmonary artery. They will end up being discolored blue or purple from the nipple line up. And you may or may not hear people say that, you know, it's probably a pulmonary embolus just based on the way that the patient looks. So pulmonary emboli and shock. Obstructive shock, eventually, if you have an obstructive shock, a pulmonary embolus will result in that obstructive shock. And remember, obstructive shock is the inability to kind of get blood flow to where it needs to go. So patients that would have obstructive type shocks may be an anaphylactic patient. It may be somebody that has been entrapped in something. So the inability for blood flow to get around the way that it's supposed to, most of the time because of some sort of a compression mechanism, whether that be external or internal, like the vessel shutting down, they're going to end up in an obstructive shock type pattern and then lead to a pulmonary embolus. The pulmonary artery blockage causes a tremendous strain on the right ventricle, and this is going to end up leading to right ventricular hypertrophy. So they'll end up with an enlargement of that right side of the heart and right ventricular strain, and we're going to see this on EKG findings. So they'll have a reduction in preload, and then if you don't have blood coming back to the right side of the heart, you don't have enough blood to pump out. So not only are we going to have a reduction in preload, we're going to have a reduction in the cardiac output as well. So here's your EKG. So there's something called an S1Q3T3 And then they're also going to have a right axis deviation. So to kind of put these numbers in perspective for you, this S1Q3T3, and what that is they're going to have that S wave in lead 1. They're going to have a Q wave in lead 3, and then inverted T waves in leads V1 through V3. So specifically, we say T3 because it's probably going to be found in T3, but it can also be found in V1 and V2. So that is what your S1Q3T3 is. If you see that, let's just say that you get called for difficulty breathing, you do a 12 lead EKG, and in your 12 lead, you notice that your patient has an S1Q3T3. They are at a 22%, based on studies that have been done, 22% likelihood that they are actually having a pulmonary embolus. That is what your diagnostic finding will probably end up being. If they have this right axis deviation shown with right ventricular strain, and we've gone over axis deviation and how you could determine that, but that right axis deviation, it is not as sensitive. It's about 16%. So 22% for your S1Q3T3 and 16% for patients that have had a right or have a right axis deviation. With some of these other findings, they're probably having a pulmonary embolus. So capnography, this is kind of an interesting thing, and with having some technology issues, I don't necessarily want to mess with it too much more. This is actually a live tracing on a machine that we can use in the paramedic program to kind of show different patterns and EKG waveforms. This is not an obstructive pattern, though. So I want to make sure that people understand that when we talk about a pulmonary embolus, that is an occlusion or a blockage in that pulmonary artery. When we are looking at capnography or end-tidal CO2, remember that is the blowing off of CO2. If it takes longer to blow off CO2, it's going to end up causing that shark fin waveform that we talk about with obstructive patterns like your COPD and asthma patient, because we all know asthma and emphysema and chronic bronchitis, it's not a problem getting air in, it's a problem getting air out. Well, if you think about it, if I put a clot in somebody's pulmonary artery, now I'm not able to get the oxygenated blood where it needs to go. It's really not a breathing out problem. So it is a different mechanism. So if you were kind of the mindset that capnography is going to show an obstructive pattern, it will not. What you will find, though, however, is they are going to be hypocarbic. So what you will probably end up finding is that their end-tidal CO2s are going to be off, and they're probably going to be low because that hypocarbia is low CO2. So we know that our normal range is 35 to 45. Your finding is going to be a little bit less than that. And as you can see here on this particular diagram, it's showing a 28. If you guys can see, that is what our end-tidal CO2 is reading. So it's clearly low, even though the patient seems to be doing okay-ish with pulse oximetry at 89%. And then clearly they're tachycardic there. It looks like they have probably, it's kind of hard to tell here, maybe sinus tach. I can't really tell if there's P waves or not. So everything else looks to be fairly okay, but that end-tidal CO2 reading is only 28%. All right, so lab values and testing, there's something called Wells criteria. And there's a lot actually that goes into Wells criteria, but some of the things that they will look at in the diagnostic phase, trying to figure out if the patient does in fact have this, is a CBC, an ABG, a BMP, and a D-dimer. And again, because we've been asked to kind of go over some of this information, I realize I am the first one to admit and realize we don't do CBCs in the field, at least not here. It's possible you can have an ISTAT and you can collect that information. We just don't do it under normal conditions. So the CBC, one portion of that CBC is really what they're looking at when we're talking about a pulmonary embolus, and that is RDW, and that is the red cell distribution width. So they want to see how big the red blood cells are, and that's one of the clinical findings is an increased RDW on your CBC. And we don't normally in the paramedic level at least talk about RDW. There's MCV. So there's all different types of values that you get with a CBC. The ones that we typically always talk about is their red count, right? What's their hemoglobin and hematocrit, and then what's their white count? Well, there's a lot more information that is contained in that CBC, the RDW being one of them, and that will help you to determine if the patient is having a pulmonary embolus. Your ABG, we can do a whole lecture on ABGs. The BMP, which is the basic metabolic panel, and then a D-dimer. So a D-dimer is a blood test. And this is kind of an interesting thing. I'll take a second to talk about it because I get a lot of phone calls, offline from various people, family, friends, colleagues that'll say, hey, let me ask you a question about a D-dimer. My mother-in-law or whoever, they think maybe she has a pulmonary embolus and this is what's going on. What do you think? So let me just kind of explain the D-dimer. So the D-dimer, what they will end up finding, or what is typical, is if you get a D-dimer drawn and it is negative, okay? Like you can hang your hat on the negative test and say, okay, well, they do not in fact have a pulmonary embolus. If, however, you or your loved one gets a D-dimer and it is positive, it does not mean that they have a pulmonary embolus or that they have this big clot somewhere that's going to cause a pulmonary embolus, is what I should be saying. What it means is, okay, well, now we need to do additional testing. So the D-dimer showing a positive finding really is the key to opening the gate to getting a VQ scan. And that's what you really need in today's world anyway to determine. There's other tests out there, the contrast pulmonary angiogram that you can see there. But most of the time what they'll do is they'll do a D-dimer because it's quick, it's cheap, and it's easy. And then if the D-dimer comes back negative, they're going to go, okay, well, it's not that. But if it comes back positive, now is when your provider is going to say, okay, well, let's order some additional testing. And the VQ scan is probably one of the next thing that's going to be in line, in addition to a 12 lead EKG. And I'll just tell you, in all sincerity, I don't know that a lot of providers out there are going to be familiar with the S1Q3T3 and that right axis deviation. So it may be something that, they say, hey, we've got an elevated D-dimer. We need to send the patient over for a VQ scan at the hospital. Maybe you pick them up at a primary care office, et cetera. Then, they may not be thinking about doing this 12 lead EKG. That is something that we should certainly consider in the pre-hospital world. And then in addition, we can look at a chest x-ray as well. So in hospital treatment, if they're hemodynamically stable, basically what they're going to do is start them on anticoagulation therapy, that heparin or warfarin. If anticoagulation is contraindicated for whatever reason, let's say that they've had a prior head bleed or they've had a hemorrhagic stroke, those types of things, and they're not going to be a candidate for any type of anticoagulation therapy, then they'll end up putting an IVC filter in, and that IVC filter is the inferior vena cava, and it makes sense. So they're going to put a filter in there that is going to end up allowing blood flow to get through, to get back to the right side of the heart, but it is going to prevent any clot that has developed. It'll end up getting caught in that IVC filter. So that is what the inferior vena cava filter is and why we would use it. But clearly that's more of an invasive thing if they have to go in and place that. So under normal conditions, what they would do is they would just start them on anticoagulation therapy through medication alone, and then send them back to get that INR drawn to make sure that they're at a therapeutic level. If they're hemodynamically unstable, then what they would end up doing, as long as they are able to do it, again, going back to your hemorrhagic stroke, if they've had a hemorrhagic stroke or any type of head bleed, then they would be, it would be contraindicated to give to thrombolyse. These clots, and the way that they do that is with TPA, and you guys are all familiar with TPA, have probably heard about TPA, and that stands for tissue plasminogen activator. So that is going to actually end up going in there and lysing or breaking down the thrombus. So the problem with TPA, as you all know, and this is why we only have a certain amount of time to get your patient to tertiary care prior to TPA administration, is because there are a lot of risk. So this becomes a risk-benefit analysis that has to be done. If it is outside of a certain window with stroke and they're pushing that envelope, then they say, look, the risk of giving this TPA are just too great. We're not going to do it because you can literally cause people to bleed to death. So if TPA is contraindicated, but your patient is still hemodynamically unstable, then what they'll do is they'll do an embolectomy. They'll go in and actually pull that embolus out. In the hospitals here in the region do have the ability to do that. St. Elizabeth and Edgewood can now do embolectomies, and certainly some of your facilities over the river are able to do that as well. If you're not in this area, what I would recommend is if you are bored and trying to do research and appropriate facilities to transport your patient to, you may want to find out which hospitals have the ability to do an embolectomy, because that would be kind of the last ditch effort. They're all going to be able to do heparin or warfarin. They're all going to be able to put an IVC filter in, and all the hospitals are going to have TPA. It's really when all else fails, we're going to have to go in and actually pull this clot out, who can actually do that and who cannot.